hope you all had a nice drive. People coming from outside the state, thank you for joining us. Welcome once again. So I don't want to prolong the time. We are already running a little bit behind schedule. So I'd like to introduce the first speaker, Dr. Ragesh Thandassery. He's got an extensive CV, so I do have to write it and read it. I'm sorry about that. So Dr. Ragesh Thandassery is an associate professor at the University of Arkansas in Little Rock. He's a transplant hepatologist, and he's also the liver program director at the Little Rock VA and also the entire South Central VA, which covers multiple states. He received medical degree from JIPMER Pondicherry and did his MD and DM from PGI Chandigarh and did his transplant fellowship from Mount Sinai, New York. So we are really privileged and honored to have Ragesh here. He's triple American board certified in internal medicine, gastroenterology, and transplant hepatology. His major clinical and research interests are hepatocellular carcinoma and complications of cirrhosis and portal hypertension. Dr. Thandassery's work has been published and well quoted. He's got over 1,500 citations in peer-reviewed journals, high-impact journals like the Gastroenterology and Hepatology International. In fact, I have been honored to co-author with him as well, thanks to him. He has received multiple prestigious research awards, including the American College of Gastroenterology Governor's Award for Excellence in Clinical Research. Ragesh, it's my pleasure and privilege to have you here and teach us about metabolic dysfunction-associated steatotic liver disease. Thank you, Ragesh.
Good morning. Thank you, Dr. Tarian, for the kind words. Thank you, Dr. Kavilaveettil and other organizers for inviting me for this talk. Let's straight dive into the topic. Today we are going to discuss about metabolic dysfunction-associated steatotic liver disease. This is actually a new name for the familiar older name that is non-alcohol-associated fatty liver disease. So the obvious question would be, why the change in name? So when we say non-alcohol fatty liver disease, it doesn't actually reflect the actual disease ongoing. It's not the absence of alcohol that drives the liver disease, but it is the metabolic complications which drives the liver disease. So the most common scenario in which these patients comes to us is imaging identification of fatty liver. So then the clinical problem we have is steatotic liver disease. So once we have a patient with steatotic liver disease, these are the different possibilities. On the extreme left, we have the condition what we are now discussing, that is metabolic dysfunction-associated steatotic liver disease, which is also abbreviated as MASLD. That is presence of fatty liver with some of the metabolic risk factors like diabetes, hypertension, hyperlipidemia, or hypertriglyceridemia. And the next group is when patients have both metabolic risk and alcohol use. So this group is called MET-ALD, in which the alcohol use varies between 20 to 30 grams for women and men respectively per day to up to 50 to 60 grams for women and men respectively. But if the amount of alcohol use is more than that, then the steatotic liver disease is from alcohol. Then we also have some rare conditions which could be due to drugs or some rare genetic conditions like liposomal acid lipase deficiency, which can also contribute to steatotic liver disease. So MASLD is a spectrum, and the largest spectrum is when they just have steatotic liver disease, and a subgroup of these patients develop inflammation. That's what we call MASH. In the past, it used to be called NASH. And once they develop fibrosis and it progresses to advanced stage of fibrosis, we have cirrhosis. And a subgroup of patients, mostly with cirrhosis, develop liver cancer. But it's important to note that a small group of patients may develop liver cancer, that is HCC, even in the absence of cirrhosis or even MASH. So the global prevalence of MASLD corresponds to the global prevalence of obesity. We see MASLD more in places with more of obesity. The highest incidence is noted in Middle East. Not far behind is United States. About 40% of adults in United States are obese, and about 30% of adults in United States have MASLD. So the common metabolic complications we see associated with MASLD are hypertriglyceridemia, obesity, dyslipidemia, hypertension, and diabetes. Once they have one or more of these conditions, they have metabolic syndrome. And as we compare the incidence of these conditions in general population with MASLD and with MASH, we see the incidence of all these conditions increase. It's important to note that even though patients have MASLD, that by itself doesn't increase liver-related mortality. It is the fibrosis that increases mortality. Traditionally, we stage fibrosis based on biopsy as F0, F1, and maximum up to F4. F4 is cirrhosis. And studies have shown that as the fibrosis stage increases from F0 to F4, the all-cause mortality and liver-related mortality steadily increases. So fibrosis is the best predictor of liver-related mortality. We don't use liver biopsy often these days. We have excellent non-invasive methods to stage fibrosis. So once a patient is diagnosed to have MASLD, the next thing is estimating fibrosis. So we calculate a FIB-4 score, which includes age, platelet count, AST, and ALT. And if the FIB-4 score is above 2.67, it is very likely that patient has advanced liver disease, that is either cirrhosis or F3 disease. If it is less than 1.3, usually it indicates that there is no advanced liver disease. But to make it more objective, we have FibroScan, which is a vibration-controlled transient elastography technique, a shear wave process through liver, and we see how much resistance liver offers to the passage of this wave. And we have two parameters in a FibroScan report, which is CAP score, the one in blue color, which indicates how much of fat is present in the liver. If it is more than 250, it means there is steatosis. And the next parameter is the liver stiffness, which is measured in kilopascals. If it is less than 5, there is no significant fibrosis. If it is more than 15, most likely patient has cirrhosis. If it is more than 20, it usually indicates that patient has clinically significant portal hypertension. And another more specific and sensitive method is MR elastography, but it's not very widely available. If the stiffness measured in MR elastography is more than 5, it means patient has cirrhosis. This is the algorithm proposed by American Liver Society. I can simplify it. So once we have a patient with a diagnosis of steatotic liver disease, as I mentioned, we calculate the FIB-4 score. So the FIB-4 score is less than 1.35. They can continue to be monitored by a general practitioner with close follow-up and control of metabolic risk. But if it is more than 2.67, it usually needs a referral to a GI or liver specialist. If the values are in between, that is when usually we do a FibroScan. If the FibroScan KPAs are high, then again they get referred to a specialist. So MASLD is a very slow indolent disease. Its progression is very slow. Once the patient has MASLD, it takes decades for them to progress to cirrhosis, and a small proportion of them develop decompensated cirrhosis, which is an indication for liver transplantation. But it's important to note that the most common cause of death in these patients is cardiovascular disease and malignancy. And third is the liver-related death. So the risk factors, as we know, are obesity, metabolic syndrome, insulin resistance. All that is indicated in red are established associations, and those that are indicated in green are protective, which includes coffee intake and exercise. Extensive studies have shown that intake of 3 or more cups of coffee reduces the risk of progression of liver fibrosis, reduces the risk of development of HCC, and also reduces the risk of decompensation. There is also a subgroup of patients who are not obese but still can have MASH. About 20% of patients with MASLD are not obese. It's more common in Asian population, so we believe that they are metabolically obese, even though they are not phenotypically obese. Some of these patients may have single nucleotide polymorphisms like PNPLA3 mutations. So it is important to consider MASLD even if patients are not obese or overweight. There is often a question about alcohol use in patients with liver disease. It is, in fact, a contributor to faster progression of liver disease. Alcohol and obesity is a dangerous combination. And extensive studies have shown that there is no safe limit of alcohol use as far as the liver is concerned. And if patients have anything more than F1 fibrosis, we strictly recommend them to abstain from alcohol completely. MASLD is, in fact, a systemic disease. Rather than talking about extrahepatic manifestations, I would say MASLD is the liver manifestation of the systemic disease, and the other non-liver related conditions include stroke, heart failure, arrhythmias, myocardial infarction, chronic kidney disease, and different types of solid malignancies like breast cancer, pancreatic cancer, stomach cancer, and colorectal cancer. MASH cirrhosis, how is it different from other cirrhosis? With excellent treatment available for chronic hepatitis C, now in North America, as well as many of the industrialized countries, the top cause of cirrhosis is MASH. The incidence has increased by 2.5 folds in the United States in last 1 decade. The challenges are these patients tend to be older. They usually have multiple medications. And if they need transplant, it becomes a little challenging as they are an older population and they may also need simultaneous liver kidney transplantation. However, the disease progression is slow. It is a very indolent disease. We often underestimate the muscle strength in patients who are obese. There are a lot of studies that have shown that obese patients can be sarcopenic, and sarcopenia can be a challenge in overall management of these patients. Sarcopenia is known to worsen the outcomes of any surgery in liver patients, including liver transplant, and they are also at increased risk of developing hepatic encephalopathy because ammonia is metabolized in muscle. Hand grip strength is something which we measure in bedside to roughly estimate the extent of sarcopenia, and once we diagnose sarcopenia in these patients, we have to counsel them extensively about nutrition and replenishment of muscle mass. These patients are also at increased risk of liver cancer, and more importantly, liver cancer tend to be diagnosed at a later stage in patients with MASH cirrhosis. That is because the screening test we do for any patient with cirrhosis is ultrasound. Once these patients are obese, ultrasound is not really a good test to detect a small liver tumor. So we often see patients, once they present to us with HCC, if it is NASH related, HCC tend to be in an advanced stage. Treatment, the most important is lifestyle interventions, increase physical activity, be active. Exercise about 150 to 300 minutes of moderate intensity or 75 to 150 minutes of vigorous intense activity is recommended. Caloric deficit, cut down the total calorie intake, but it's important to make sure that they are not sarcopenic. There should be protein supplementation. Discontinue weight promoting medications. All these patients tend to be on multiple medications. Carefully look at their medication list. Medications like mood stabilizers, antidepressants, then oral contraceptive pills, beta blockers, angiotensin receptor blockers, they all can cause weight gain, and make sure that we tell them not to take any of this. And most importantly, alcohol minimization. So this is abbreviated as ABCD for lifestyle interventions, which is the first step in management of these patients. Weight loss has been shown to improve all the markers which we usually follow in patients with steatotic liver disease. If they can achieve a weight loss of more than 3%, studies have shown that steatosis improves. If the weight loss can be increased to more than 5%, we see improvement in ballooning and inflammation. If there is more than 70% weight loss, MASH resolves. If there is more than 10% weight loss, fibrosis stage can improve. If these don't work, we go to medications. And there is an overlap between medications we use to treat obesity and MASLD. We can roughly put all these medications into two baskets, one that is used for treatment of obesity and another for MASLD specifically. There are a lot of medications, but we now focus on these medications which are highlighted. For obesity, semaglutide, which is a glucagon-like peptide receptor agonist, which is marketed as either Wegovy or Ozempic, or tirzepatide, which is marketed as Mounjaro or Zepbound. And recently, we have resmetirom, which is specifically approved for treatment of MASLD. So enteropancreatic hormone-based treatment is now the mainstay of treatment of obesity and diabetes. And we know these peptides like gastric inhibitory peptide or glucagon-like peptide 1, they all have multiple actions. They reduce gastric motility, increase insulin release, decrease appetite, and they all help to promote weight loss. And the backbone of all the enteropancreatic hormone-based treatment is GLP-1 agonist. This diagram roughly summarizes all the medications which are currently approved and in different stages of clinical trials. We already have Wegovy and Ozempic, which is GLP-1 agonist, and we also have tirzepatide, which is a combination of GLP-1 agonist and GIP agonist. In 2021, an NEGM study had shown that semaglutide improves NASH and also improves fibrosis in patients with non-alcoholic steatohepatitis. So these are the two endpoints we use in studies for MASH, that is improvement in inflammation and improvement in fibrosis score. Subsequently, another study in Lancet had shown it helps also in patients with cirrhosis. And recently, just 2 months ago, we have the first FDA-approved medication only for treatment of MASLD, which is Resdifra, that is resmetirom. And this NEGM study has shown that patients have improvement in NASH and also fibrosis scores. It is the only FDA-approved medication for MASH, which is weight neutral. It doesn't act by reducing weight, but it reduces it increases the lipid oxidation in liver and thereby reduces hepatic steatosis. Rarely it can cause hepatotoxicity, and there are some rare drug-to-drug interactions. A main question which we get when we manage patients with MASH is, can we use statins in them or not? Answer is yes. Statins can be used and they should be used to control other metabolic risks. We should be cautious if they have decompensated cirrhosis, that is child B and child C cirrhosis. We usually do not give statins. Once pharmacotherapy fails, we go ahead with surgical options. There are strict criteria for considering these patients for surgery. Even with surgery, we sometimes see regain of weight. About 25% of patients can regain weight. This is an excellent study published in Lancet that combined lifestyle intervention with bariatric surgical procedures, and it has shown that both NASH and fibrosis improves more in patients with bariatric surgical interventions. But this particular trial did not include the newer medications like semaglutide and tirzepatide. The final treatment for patients with decompensated cirrhosis is liver transplantation. There is no cutoff of BMI. Sometimes some centers do combine bariatric surgery and liver transplantation. Sadly, disease can recur in patients. After transplant, if they had had transplant for MASLD, about 80% of them have recurrence of MASLD. If they had transplant for non-MASLD related indications, these patients also have about 40% recurrence of MASLD after transplant. And we also see that MASLD recurs faster in patients with transplant. It is an indolent disease, but after transplant, with immunosuppression, metabolism changes, and they have faster recurrence of MASLD. To summarize, MASLD, which is a new name for non-alcoholic fatty liver disease is becoming the most important cause of liver disease, cirrhosis, and indication for transplant in the United States. The mainstay of treatment is lifestyle interventions and then medications. If they fail, surgery should be tried. It is usually a multidisciplinary care. The team includes the primary care team, nutritionists, then surgeons, liver transplant team, and hepatologists. We all work together to manage this condition. I have some pictures from Little Rock. This is Hot Springs. This is the Ozark Mountains. This is Buffalo National River. This is Crystal Bridges Museum. And this is Pinnacle Mountain.